Thank you, Rita, for giving me this opportunity. I am going to talk only on the identification and not the management part of late blood failures. No financial interest. These are the bloods which you always aim for or dream for. So trabeculectomy is the most widely used surgical procedure for glaucoma, and in spite of use of anti-metabolites, we still see the lot of cases of failure, and at the end of 5 years, almost 50% fails. So identifying late blood failure is also a very important topic. Now, what is the definition of failed blood? It's defined as a loss of glaucoma control with or without supplemental medication at some point in the post-operative period. Early blood failure usually it's arbitrary. It can be within 6 weeks of the post-op, and later on you can call it as a late blood failure. Now, in identification, I have put up 3 steps. First, you have to suspect that this is a patient who is likely to fail. Then evaluate the blood and then confirm your diagnosis. And this is a list of risk factors. These are the patients who are likely to fail whatever you do. So keep an open eye and suspect. Do more follow-ups in these patients, like young patients, previous surgery which has already been failed, or some retinal surgery has been done, bad conjunctiva, or patient is using multiple topical drugs for a longer time. So this conjunctiva is not healthy. So many patients are listed here should be suspected for the late blood failure. And evaluation, believe me, late blood failures, the only correct sign is the intraocular pressure. So serial evaluation of intraocular pressure, which is showing rising titer or rising trend, should be suspected as a late blood failure. The slit lamp examination is being said in detail, but these are the points usually we look for. And for me, gonioscopy is also a very important tool. By and large, the late blood failure is because of the increased vascularization and lot of fibroblastic activity in the subconjunctival as well as in the episcleral space. And rarely it could be because of the obstruction of the internal ostium, because of the synovial tissue or fibrin material in the ostium. So before you do anything, please do gonioscopy, and these are the classic example. You can see the uveal tissue, the process coming in and blocking the window. Here the iris pillar has come up and blocked the window. So if you can identify this, you can manipulate and do something else for this. Now, slit lamp evaluation, whatever classification is being described, it gives you a subjective finding. But how can you do a better evaluation? First is have a diffuse light, and overall appearance of black should be noted, and then have a thin oblique light slit which will give you the transparency of the conjunctiva. It will also give you the depth of the penetration and what is happening underneath. Though very difficult, but sometimes we can manage, and look for some microcystic changes also in the area of the blood. The Morfield classification requires the photo slit lamp, and you have to keep this whole chart near to your slit lamp, and this has to be compared with your own findings. So this becomes a subjective. IBEX, as Dr. Manisha said, includes the serial test, so whatever is convenient to you, you can use it. But whatever is seen here, usually this is good for the early blood failures. In late blood failures, usually this is not seen. And the limitations of slit lamp evaluation is shown here. See, this is also very good high elevated blood with the pseudopoias here. And this is also one of the avascular highly elevated blood, but this is not a functioning blood. So we don't know what is going on internally. The late blood failures is because of the internal morphology change. So a clue to the late blood failure, first, as I said, is always a gradual increase in intraocular pressure, change in the blood appearance. Relatively it becomes avascular, non-transparent, and diffuse or almost flat. I don't think vascularity plays much role in the identification. Now, this is a case where it is a successful blood, IOP well on the target without any medication. 18 months follow-up is shown, 2 months, 3 months, you can have a good elevation, slit lamp examination with the slit. a small microcyst at 6 months. Gradually some pigments came and disappeared also. Still elevation is persistent and good vascularity, pseudopodias, everything is fine in this case. Now this is another case, 1 year follow-up, lot of vascularity here to start with at 2 months, but the elevation is good, the area occupied is almost 2 o'clock. What is happening here? Now see the gradual change in the transparency of the bleb. The color of the bleb is also becoming white, opalescent in this area, becoming flatter and flatter, and gradually this was a non-functioning bleb. Alternatively, an elevated and large blebs like this can be there, which is an encapsulated bleb, and I will not be discussing this wall of fibroblastic ring. It has already been done by the previous speaker. So clinically, essentially clinically good looking bleb like this may not have a good bleb function like in this case. And why it is so? Because as I said, there is a limitation with the slit lamp examination, internal morphology cannot be seen. So in these cases, maybe using an imaging technique will guide you what is happening underneath. Like this is the bleb, and you can see a beautiful hyporeflective area, spongy look, subconjunctival separation and multicystic block. While here hyperdensity echoes with a very thick bleb wall, which is a sign of a failure. So imaging can be utilized in late bleb failure. You can use intersegment OCT or UBM, and this is how it has been described. You can see the subconjunctival fluids fill space of a hyporeflective area or variable reflectivity in this wall. And then there is a scleral flap. You can see the ostium here with the suprascleral fluid spaces. And these bleb wall can be classified into bleb wall reflectivity and bleb wall pattern. Look for the hyperreflective areas and root beneath the scleral flap. And this is a classic example of bleb wall reflectivity, which is uniform in nature. Here you can have a multiform reflectivity areas with a small pockets of the aqueous underneath. And this multiform reflectivity wall can have a three patterns, and one bleb can have all three patterns. Like this is a bleb wall with the multiple internal layers. Here subconjunctival separation and a spongy loop and large cystic space here. And this was a multicystic bleb. And of all, the multicystic bleb found to be long-lasting in one of our study. This is a failed bleb showing you the hyperreflectivity or dense area of the fibroblastic activity here, though the root beneath is patterned and have a small aqueous pocket here. This has been already shown multiloculated cystic bleb with a small and large cyst with a spongy look, but these blebs are of a high risk variety where the blebitis is a frequent occurrence. And this is an encapsulated bleb showing a very thick wall, which is showing you a boundary here. And this is a failed bleb or flattened bleb with no bleb elevation and high scleral reflectivity. So evaluation of failing bleb or OCT can guide us about which bleb is likely to fail in the future. And uniform reflectivity is a sign of failing bleb. Now this is another case where at the 6 weeks you have a beautiful bleb underneath. You can see the subconjunctival separation, large cyst, multiple microcysts. But what happened on this bleb? After 12 weeks, the elevation is still same, though there is a change in the transparency. And here you can see the lot of fibroblastic activity going on in this area. And at the end of 12 months, there is absolutely flat bleb with no hyporeflectivity areas. Another case where at the 6 months with a good follow-up and good IOP control, at 3 months the same bleb became flat with hypervascularity. The IOP went up to 36. We did the needling, and after needling you can see change in the pattern of the bleb wall. So identifying a late bleb failure, still I believe IOP is the most important parameter. Never forget to do gonioscopy to see what is happening in the inner fistula. And segment OCT or UBM can be a good adjunct to your clinical judgment, and you have a scope for the early intervention. Thank you very much.